The PTCL, scattered cells, this is strong and uniform. Now, the reason this, I will tell you a story, the reason this ended up in the WHO in 2008 as a provisional had to do with these data, which were generated by a colleague of mine in Vancouver, Carrie Savage. So certainly we knew that ALK positive in the dark here has a much better survival, either overall or failure-free, from ALK negative. We already knew that. But in the data that they generated in that blood paper, they also found it seemed to have a different survival than PTCL. And it was on the strength of this, which has now become questioned a little bit in the last 6 months, it was the strength of this observation was the need to separate it from peripheral T-cell lymphoma unspecified, or NOS. That's how that happened. Who knows what will happen in the next one. And remember, there is a primary skin-based form of this disease. Again, more often males than females, typically solitary lesions. Some may regress without treating. It's non-epidermotropic, of course, and you get sheets of these big cells. It is a T-cell disease. It is ALK negative almost always, but Elaine Jaffe, Nancy Harris, and I have collected 3 cases of isolated cutaneous lesions in older patients that are screaming ALK positive. And they all actually have the same ALK type staining, which is interesting. I presented one, as some of you remember, at the meeting in Los Angeles. Very interesting. These are clonal, and by definition, neither of these translocations will be evident. Well, that doesn't show very well, does it? So just to remind you again of these cutaneous CD30. So here's a cutaneous ALCL, solitary lesion, as you mentioned, mostly neoplastic cells, and by definition, usually always ALK negative. In contrast to LYP over here, where you get crops of lesions that come and go. They have characteristic histology, which we won't bore you with. And then, of course, systemic ALCL, which I can't even read. I don't know what happened there, which we talked about the clinical features. And usually, by definition, we're talking about ALK-positive disease. Now, let's move along again. Extranodal NK-type disease, nasal-type disease. So typical presentations occur in the midline, involving the nasopharynx predominantly. But remember, this disease can present at a number of extranodal sites, including skin, GI tract. It is more common in Asians and may be associated with hemophagocytosis in the marrow. It has characteristic histologic findings that one sees here. It has a typical phenotype. CD2 is positive, surface CD3 negative, but cytoplasmic epsilon chain is positive for CD3. And most pathologists recognize that pattern of staining. 56 is pretty much uniformly expressed, and of course, besides the cytotoxic molecules, it's EBV positive. There are some cases, however, that are clearly T-cell that have exactly the same presentation, and when you PCR them, they're clonal. Here's a nice case here, as you can see, CD2 expression, beautiful CD56, EBER positive, and if you make imprints like I did for 20 years in Vancouver and stain them with Giemsa stains, you can see the aerophilic granules. This is a touch prep from the nasopharynx, as you can see, and perforin positive. And remember that classic presentations occur in the midline, but others can occur at those other sites that I mentioned. So I think here comes case 1, Mexico City. Make sure everybody's awake. This is for the pathologist now. I'm not going to be asking the clinicians, so you're off the hook for now. So this is a case I saw recently in Vancouver. 73-year-old Chinese female presented with multiple skin lesions involving thigh, abdomen, and gingiva. A little bit of a clue. Skin biopsy was taken from one of these lesions on the abdominal wall. She was treated with CHOP, but unfortunately she died 2 months later. So there's the biopsy. That's what they looked at, a little higher power, quite a dense infiltrate involving the full thickness of the dermis. Anybody want to hazard a potential differential here? Oops, I think we're having to, oh, that's the wrong one there. So, anybody want to offer up a possible diagnosis on the basis of what we just spoke about? So here's the biopsy. It's CD2 positive. You can see it here at higher power. That's the EBER. 100% of the cells are positive, 56 positive over here. And I can't read what that is. Such as 56 at higher power? Yeah, so this was a non-nasal presentation of that same extranodal type TNK cell disease. So you need to think about these things as terms of differentials and remember to do the stains. So remember that when you see these kinds of diseases like this that are CD56 positive, you have a differential diagnosis. And there are clues that we use to help us sort out that differential diagnosis. But remember, there are other tumors that may enter into this differential that we're not talking about tonight. All right, so the systemic disorders is listed here. Again, there's still something funny about this list, and I'm missing a disease that we spoke about. So here's T-cell PLL. This is a very uncommon diagnosis in my experience. Patients present with extremely high white counts, like usually over 100,000. They have big spleens, and they're very sick, and you can have the typical look that looks like this, but remember, there's also a small cell variant. And they have a uniform cytogenetic finding that's present in virtually all the cases. Here's a classic case of Sézary. This is remember the peripheral blood manifestation of mycosis fungoides, as you can see. It has a characteristic morphology when you see it that's very characteristic, as is the clinical picture. And if you do flow, you remember you find these T cells, but they've lost expression of CD7, which is a characteristic finding. Large granular lymphocytic leukemia is something we spend a whole lot of time diagnosing and doing PCR on in Vancouver, and I'm not sure why, because generally speaking, these patients don't get treated with very much, and they're often extremely indolent, but we PCR the heck out of them. Now, here's our case that was presented today, and that's why I didn't see that on my list, unless I'm just tired. Was that on my list of systemic? No, it wasn't. So, okay, so we have a little work to do on the plane home to fix some of my slides. As I mentioned to you, when I saw all those cases in Japan, they can look like a million different things. And again, it begs the question about testing. Now, I would ask you, some of the pathologists in the room, when you see a case that you suspect here, do you do serological studies, or do you look for clonal integration of the virus? Because in Japan, all the cases that we saw, they don't bother with serology because if they come from an endemic region, the seroprevalence is 15 to 20%. So for all of them, they do southern blots that demonstrate clonal integration of the virus. Do you do that here, or do you just, you basically, and so I heard, or I saw some very nice immuno, by the way. I do the same thing. I use CD25. When I see a CD4 positive type disease and I don't have any history to tell me about what their nationality might be, where they might be from, and that's what I mentioned in that early on slide about problems with not diagnosing this in non-endemic regions. I use CD25 as a pretty good screen. If it's positive, then I start really thinking about HDLV1. In Vancouver, what I then do would be a FOXP3, and that was a very nice stain. And in addition, I would recommend serologic studies. But in Vancouver, we don't do clonal integration just because it's an extremely rare diagnosis to make. Here's another CD56 positive disease, but again, extremely rare. I've only ever seen a couple of these in my life. Now, the primary cutaneous disorders, we'll just go through very quickly. We've talked about some of these already. Classic MF, we see a lot of this. Can be very hard to diagnose. Patients often have multiple biopsies over many years before somebody pulls the trigger and says, you know what, this is mycosis fungoides. Immunohistochemistry can be helpful, as is other approaches. Now, cutaneous gamma delta we heard about. There's the clinical features as shown here. This is an aggressive neoplasm. It can be epidermotropic, dermal, or subcutaneous. It has a number of different patterns. The phenotype is very characteristic, but as I mentioned on the earlier slide, CD56 positivity is one of the differential findings that's quite helpful. If you do TCR for gamma, you'll find clonal, but for T beta, of course, it's not. And cytogenetics are not known. This is a slide that Elaine Jaffe gave me that's from a paper from several years ago showing some of the clinical manifestations of this disease. They can be kind of nasty looking. Here's a recent case I saw in Vancouver with the typical histology that you see. Here, again, CD2 over here. It's cytoplasmic CD3. Here's CD4 and 8, both negative. That's a clue. It doesn't mean that it's gamma delta when it's negative for both 4 and 8, but it's a good clue. Here it's stained now for alpha beta and around the same actual area where gamma delta is nicely positive, the alpha beta is negative, as you can see, and 56 positive and also cytotoxic molecules. So keep in mind that gamma delta T cell lymphomas are an expanding group of diseases. So those of you who've been doing hempath or doing hematologica for a while will remember that when Elaine Jaffe and others first described subcutaneous paniculitic, there was only one category, alpha beta. And then a few years ago, we realized that there is a gamma delta type. We've also seen that with hepatosplenic and other diseases. And what I can tell you, there's now a growing body of literature that there are probably gamma delta subtypes within many of the usual categories. And what will happen